Additional speakers. So next up is Dr. Jim Lash, who is the Robert Wood Keaton Professor of Medicine and the Chief of the Division of Nephrology at the University of Illinois College of Medicine. His research focuses on the epidemiology of chronic kidney disease and interventional trials in the treatment of kidney disease, particularly among racial and ethnic minority populations in the U.S. Dr. Lash is the UIC Principal Investigator for the NIDDK-sponsored chronic renal insufficiency cohort and the Hispanic CRIC studies and the University of Illinois at Chicago Kidney Precision Medicine Project CKD. In addition, he is a generous mentor and a skilled clinician who focuses on treatment of hypertension and kidney disease. So thank you.
Thank you, Milda. Thank you, Albert, for the invitation. I'm delighted to be here today. And it was very exciting to hear about the vision and mission of this center, and really proud to be part of this symposium. So I'm going to be talking about a really important observational study in chronic kidney disease and some of the what's been learned from this study. So I'm going to start, first part, I'll just give an overview of the study, rationale for it, and then some select findings. And Irene pointed out to me last week that the length of this talk, so it's very select findings and just a potpourri of the types of things that the study has really been able to examine, kind of using a socio-ecological approach, and just highlight some important things. So Michelle and our earlier speakers brought out, the problem of end-stage kidney disease in the U.S. and the disproportionate burden of kidney disease in racial and ethnic minorities. And here we see incident rates for end-stage kidney disease. You can see the marked elevated rates in red, which represents Black patients, and in the middle are Hispanics and Native Americans, and white patients have the lowest rates. Okay. And as Michelle also pointed out, that's the tip of the iceberg. There's over 32 million adults in the United States with earlier stages of chronic kidney disease. And here we see by stage, the number of individuals in millions. You can see it's a very large population. So, the NIH or the NIDDK recognized this problem. And I think this also pertains to some of the points that Michelle was making in terms of kidney disease being an under budgeted research priority for the NIH. So we had decades of experience of cohort studies done for cardiovascular disease. Of course, the most famous was the Framingham study, but a number of them, a whole slew of them, which would span decades, which really helped define, what we know about cardiovascular risk. So much later in the game, NIDDK recognized the importance of gaining a better understanding of the epidemiology of CKD, and put out an RFA to establish this study, the chronic renal insufficiency cohort study, with the following very broad research objectives. And one was to really create a vibrant network, sort of a clinical research laboratory in CKD epidemiology, and specifically to look at examines, patterns, and risk factors for progression of CKD and the associated cardiovascular disease, to develop predictive models to identify higher risk groups, and to identify potential etiologic factors for future treatment trials. And so the network was established, and there are 7 clinical centers across the US. And just want to run through so the funding for the study began in 2001, and we started recruitment in 2003. And we can see that there's been various phases of the study. There was an initial recruitment of a cohort of almost 4,000 patients. We then instituted follow-up. And then more recently, you can see that there was an additional 1,500 patients recruited. And then during a more recent phase, we sort of implemented some home-based protocols, which I will not be discussing today. And then just to sort of talk about our activities at UIC, we recruited for the main part of the CRIC study about 521 participants, and then an additional 215 later. But because we have a very substantial Hispanic patient population, we're also very interested in the problem of chronic kidney disease in that population. So through a ancillary RO1, we recruited a cohort of Hispanic patients with chronic kidney disease and who have really are fully integrated into the overall cohort. And we'll also briefly mention that we have a collaborator in Mexico City, and through a Fogarty initiation funded project, we are working with a nephrologist in Mexico City, Magdalena Madero, at the Cardiovascular Institute, and who has recruited a cohort of Mexicans with chronic kidney disease. So we can look at do some very interesting comparisons that I'll touch upon later. So study design is a prospective cohort study. The inclusion criteria is basically, it was adults with an estimated age of basically CKD 3 and 4. And then the exclusion criteria are listed as listed there. And then there was a nested subcohort design in terms of about 1/3 of the cohort had slightly more intensive testing at baseline, which included iothalamate GFR, coronary artery calcification. And so the basic study contact was, annual in-person visits and 6-month phone calls to examine change in status. And certainly at the baseline exam, of course, it included the usual data collections regarding medical history, physical measures, psychometric measures, blood and urine collection. And then, of course, the main clinical outcomes that we examined were, of course, CKD progression related, and also very carefully have examined cardiovascular outcomes with an adjudication process for patients who are hospitalized with a cardiovascular event. And then this is just sort of to give you an idea of some of the data which we collected, which the study has collected, and some of it was collected in the entire sample, some of it was collected in a subsample, but it's a very rich data set in terms of different types of things that one can look at. So I think it's important to get a flavor for what the phase 1 or what the earliest cohort what the cohort of 4,000 individuals. And you can see at study entry, they were, just below 60 years of age. We had a good male-female representation. You can see that 42% of the cohort were Black patients, 13% were white patients. About half the cohort had diabetes, which was intentional because then we could examine outcomes by diabetes status, which is very useful. And you can see blood pressure at study entry, BMI, of course, on the higher side, not unexpectedly estimated GFR about 45, and median proteinuria was about 0.18. So it was a little lower than what we thought we would see, but that, I think it reflected, therapy with ACE and ARBs. And then in terms of study outcomes, this is very, updated data from, there's something called CRIC Data View, which is openly accessible tool. And so you can see that the cohorts experience significant number of events, and these are events expressed in per 100 person years. So you can see cardiovascular events, CKD progression events, death. And so it really allows one to look at a variety of associations. And here just represents the studies you'd really resulted in the publication of like over 500 manuscripts, some of it using data from the NIDDK repository, and that's a growing number, and I'm going to talk about that as an important resource. And you can see in blue sort of represents, I'm not going to talk about all 68 publications, but it represents some of the issues that I wanted to highlight regarding CKD management, health equity. So that's okay. So beginning with sort of a few publications that looked at neighborhood SES. And so I wanted to begin with the most important one. This was led by Milda Saunders and Avi Aronov, who was a R35 fellow who is now doing cardiology fellowship at Vanderbilt. So this examined neighborhood SES and the risk of cardiovascular events. And this is, really an important issue to look at. It's been, established in the general population or the non-CKD population that the neighborhood SES is associated with cardiovascular outcomes. But is this true in patients with CKD who are already at increased risk for cardiovascular problems? So the exposure was, neighborhood SES quartiles, and it utilized a validated neighborhood SES summary measure of 6 census-derived variables. And then we looked at these various cardiovascular outcomes. And so just to give you a flavor, so what's beautiful about CRIC, we have the patient's geographic address, but we can look at the neighborhood attributes and we can look at the individual attributes. And as you would expect, we see some marked differences comparing the lowest quartile to the highest quartile in terms of age, sex, race, ethnicity, obviously individual income, in terms of nephrology care, interestingly, slightly higher in the lower quartile, probably because CKD was more advanced in that patient population. And then in terms of comorbidity burden, we see, marked differences in terms of the prevalence of diabetes, hypertension, smoking, recommended physical activity, all very important factors to be considered in, trying to improve outcomes for our patients. Also can see that GFR was lower and urinary proteinuria was higher. And so this shows the crude event rates for the various outcomes that were examined. So we can see that for heart failure, there was like almost a graded difference in terms of rates. And with myocardial infarction, which happened not quite as marked, but it's a less common event. And for death, again, very much a graded association between neighborhood SES and death rates. And in the multivariable associations, there was a significant association by interaction by GFR level. And what we see is that in those who had a estimated GFR at baseline of more than 45, we see that the neighborhood SES, that the lowest quartiles were associated with increased risk for incident heart failure, which is really, and this is after adjusting, of course, for the usual suspects as listed below, which includes, individual level SES. And for death, we saw, again, a significant interaction by age, and we saw amongst those who were younger, less than 60, we also saw this association, perhaps not as a dose effect, but there is an increased risk. And, what we said in the discussion was in terms of GFR, maybe those with lower GFR, maybe their cardiovascular risk is they're at such high risk that the neighborhood doesn't matter. And we thought perhaps it was the same thing with age, but of course we don't know. Yes. Okay. So CRIC has because we collected a lot of we had a very careful collection of data regarding hospitalization. And for every hospitalization, we got the records, we looked at the codes, and there's an algorithm. If within the top 5 codes there was a cardiovascular outcome, then they were de-identified and centrally adjudicated. So we have a lot of very interesting information about hospitalization. So this is another important paper led by Dr. Saunders. And again, using the same neighborhood measure census, looking at those same validated neighborhood SES measure, looked at risk of hospitalization. And we can see here our crude rates, and we can see going from lowest to highest quartile, we see that a graded difference in terms of crude rates of hospitalization. You can see they're broken. You can see the total as well as cardiovascular and non-cardiovascular hospitalizations, and that this pattern was seen in men, in women, in individuals who are younger than 65, more than 65. Again, we saw, if we looked at whites, non-white patients, and also by GFR, we see differences, that same sort of difference. So in the multivariable Poisson regression that examined the association between neighborhood and SES and hospitalizations, we see that, model 2 adjusted for the individual level SES factors. And we can see in that model that the lowest SES neighborhood, individuals residing in that neighborhood had a 32% elevated rate ratio compared to the highest SES neighborhood, and that this association really remained quite robust even after adjusting for additional clinical risk factors. This PLOS Medicine publication looked at sort of just overall defined characteristics of hospitalizations in the cohort. And we can see that, by age, we see some important differences. Of course, rates going up. We can see some differences by race and ethnicity. Diabetics, higher rates of hospitalization, as one would expect, than non-diabetics. And I think it's also useful because they compared hospitalization rates compared to the national inpatient sample. And we can see that, for many of these important subgroups, that the rates are almost triple, amongst individual CKD. And so obviously this is something that is, leading to great resource utilization and, really carefully thinking about some of the factors responsible for this could, obviously have a big impact on patient outcomes. This is another interesting analysis that looked at hospitalizations that was led by Dr. Anand Shrivastava. And he used a latent class analysis to define 3 trajectories of hospitalization during the first 4 years of study entry. And so you could see they were able to, isolate 3 different groups, a sort of a high utilizer group. So this group had a high burden of hospitalizations. There was an intermediate group, and then there was a group that really had almost no hospitalizations. And so that was the exposure year. The exposure period was the first 4 years of the study, and then they looked at the associated outcomes. And here are the characteristics of the individuals belonging to these 3 different groups. And we can see that there's some important differences by age, as one might expect, by race, so that Black patients were overrepresented in the high utilizers. We see some BMI differences, diabetes, patients with diabetes, high utilizers, pre-existing cardiovascular disease, lower GFR, and more proteinuria. And so looking at outcomes, the high utilizer group had a markedly elevated rate of a risk for developing end-stage kidney disease. And we can see that there's a great gradation here. Intermediate utilizers also much at higher risk than the referent group. And the same thing for death. The same pattern was observed for death. So it makes us think, are there modifiable factors that could be addressed? And so, heart failure hospitalizations are very common for CKD patients. We all know about that. And those of us who do adjudications, have to decide, is this is there heart failure? Is there moderate? Is it highly likely? Or is it, definite? So, so this was a very nice paper led by Nisha Bansal looking at the burden and outcomes of heart failure admissions. And again, she saw some important differences in terms of patients who were readmitted with multiple heart failure admissions in terms of race. And she also looked at outcomes, and that individuals, again, it was very sort of similar to the Shrivastava paper in that individuals with repeated admissions for heart failure were at higher risk for CKD progression and death. Again, in their discussion section, they talked about, setting up systems to more aggressively or, more proactively manage patients who are admitted with heart failure. I mean, there are heart failure programs, but maybe our CKD patients are not being captured by those or systematically. Source of care. Okay, so in this paper, we examined, there was a subset of patients, we asked patients, where you usually go for care? And a subset of patients, about 9% surprisingly, reported that they rely on emergency department or urgent care for their source of primary care. And, which was obviously very disappointing that this would be the case in a study that's at academic medical centers, and that the individuals who fell into that category really fit were a vulnerable population in terms of socioeconomic status and severity of their CKD. And so in this paper, we saw that these individuals, this small but important population of individuals were at increased risk for all-cause hospitalizations, including both non-cardiovascular and non-cardiovascular, as well as an increased risk of death as compared to those who identified as having a primary care physician. Okay, and I'm just going to move along a little bit. But this is an interesting paper. So in this paper, this just included Hispanic CRIC participants. And at study entry, they were administered a very interesting survey that I had never been aware of before, but it's sort of really it assessed the patient's experience with a primary care physician. And so it looked at 4 domains that are listed here, communication quality, health promotion, interpersonal treatment, trust. And the analysis showed that those with low scores across those domains were at much higher risk for hospitalization. So something else, another factor to take into mind. Michelle was talking about the influence of nephrology care and in terms of access to transplantation. And in this paper, examined nephrology care, and remember that about 2/3 of the cohort, about 65%, reported having a nephrologist. So about 1/3 didn't. And their attributes were significantly different in terms of age, sex, severity of CKD was less severe. And in this paper, they really found even though they used propensity score matching, they found no association with outcomes. I didn't want to include this slide, but but it may be the right, there's a number of potential reasons. Maybe if we had examined later CKD, maybe it's just our sample. Maybe they're receiving excellent care from in internal medicine. And we have very little time, but we have a very strong interest, as I mentioned, in terms of Hispanic kidney health. And so this is sort of one of our papers where we looked at baseline characteristics and we looked at risk for CKD progression. And so I think some of the things that stand out are, if we just emphasize the Hispanic subgroup, are the sort of high proportion of individuals with a low income, high proportion with diabetes, lower GFR, so that CKD is being probably detected later in these individuals. And so we also were able to look at some of the disparities in CKD management. And health behavior. So we could see some differences. You can see that Hispanic white blacks are displayed in that order, but we see some differences in terms of current smoking, not being a current smoker, large differences in ideal blood pressure control, and some differences in medication use. here we're seeing rates of CKD progression, and we see Hispanics, whites, blacks in that order, and we can see, certainly markedly elevated rates. And this is sort of loss of GFR. Again, following that, so these are white patients, Hispanic patients, Black patients, Hispanic patients. And so in our multivariable analyses, which I think are very, when we compared Cox proportional analysis, where we compared Hispanics to whites, we can see that in our first model, which includes the variables listed, that Hispanics were at increased risk, had a hazard ratio of 1.81 for CKD progression compared to whites. But after adjusting for proteinuria, this became non-significant, implying that, maybe that's potentially a modifiable risk factor. I'm going to skip ahead a little bit because I know that I'm late. I'm going to let you know just mention that, okay. So you're missing many interesting things. Okay, so just interesting, we have a cohort in Mexico City. And so this is one of our medical students. And I think, in terms of trying to increase our pipeline, we want to try to capture medical students. And I know that's something that many of you do. And so this paper was led by Clara Larkin, who participated in our T35 summer research training program for medical students between first and second year. And so she looked at cardiovascular health metrics in our cohort in Mexico compared to a cohort of Mexicans with CKD living in Chicago. So Mexico City versus Chicago. And so, I don't know what happened here. Sorry, I thought I was there. Okay, so yes, now I'm on the correct slide. So there's some very interesting differences that you can see. So differences in smoking, diabetes more prevalent in Chicago, blood pressure control much worse in Chicago, GFR a bit lower, but not tremendously lower, and proteinuria slightly higher. ACE inhibitor use lower in Chicago. And so when Claire looked at, did logistic regression for, sort of the AHA Health Life 7, we can see that in terms of having a good score, the Mexicans with CKD in Mexico were about 20% more likely to have a favorable score to our Mexican patients living with CKD in Chicago. And we see similar when we look at BMI, dietary sodium intake, cholesterol, blood pressure, glucose. And then another one of our medical students this past summer examined sort of like metrics of psychosocial health. And so she compared, using the Beck depressive inventory, compared depressive symptoms, looked at sort of depressive symptoms in Chicago versus Mexico, and you can see marked differences, and then looked at low health-related quality of life. Again, some very marked differences. And then social support, which is, an important buffer for, coming to a new society. Again, much more likely to have low social support in our patients living in Chicago. And CRIC has had a number of papers which have looked at these factors in the cohort overall, and they're associated with poor outcomes. So it's, important for us to think about this, and then trying to think about sort of a conceptual model for trying to bring together these types of factors and how they impact on income from the neighborhood to individual to psychosocial health, risk factor control. And this is sort of a conceptual model that we've used in several grants. And CRIC data view in terms of, resources that you can use. So this is a very nice tool that you can just go to the CRIC website, cristudy.org, and you can look at any factor and stratify it. You can look at, events by, age, sex, a number of things. And then the NIDDK, because we're now entering the last phase of CRIC, the NIDDK repository has both specimens and data which are available to the public. And the what needs to be done to get the data is not that complicated. So there's an increasing number of publications from the data. So I think it's a really great resource to look at. We can't examine some of the new drugs, the SGLT2 inhibitors, GLP-1 agonists, because they're more recently online, but still many other issues that can be looked at. And just want to acknowledge colleagues and collaborators, as well as grant support. So thank you so much.
Dr. Lash, one of the findings that I hadn't seen before, what do you make of the really different outcomes between Mexico City and Chicago Mexicans, given that seems contrary to some of the things that we've seen in terms of the healthy migrant?
Yes. Yeah, it's a very complex issue. And I think that, people have looked at this, and there's, you need to look at examine the factors driving immigration. Our population, I would say about 80% of them were born in Mexico, not in the US. So what are the factors driving migration? And we know that those factors are often, lack of resources, poverty, discrimination. So then you come to a new environment, and you don't have health care, and then you're facing a whole new society, different dietary patterns, different stresses, psychosocial stresses. So I think that's kind of one would hope that coming to US would mean access to health care and better disease control, but that's not the fact.
Given the success of CRIC, what is the next step in the study, and how might people sort of participate in that?
Yeah, so we are, we're in our last period of funding, so we're following the cohort for another 2 years. The coordinating center, is going to stay online for a full 5 years, but we are. There's the NIDDK repository. We're also trying to we're obtaining consent from patients. We're going to sort of have a healthy broker so that future researchers, if they wanted to reach out to our participants, could. But we're also part of a new initiative, the Kidney Precision Medicine Project, which hopefully is its goal is sort of to continue some of the basic things that we learned in CRIC, but its goal is patients, when they enter that study, they have a research kidney biopsy. And its goal is to really more precisely define, etiologies of kidney disease so that we, have more precise treatments for the right. Yeah. Thank you.